Hello students, today I am taking another topic of pharmacology, that is drug for the congestive heart failure. So it will be covered under these headings. What is a heart failure? Its important causes. What are the various type of heart failure? Pathogenesis, and what are the important drugs we use for congestive heart failure or for the heart failure. Now what is the heart failure? So normally what happens? The atria contract, आपका ये left atria contracts, it is going to push the blood towards the left ventricle. Then left ventricle, it contracts, then it is going to push the blood towards the aorta, the whole blood and the whole body, it is going to get the blood, and a residual amount of 60 to 70 ml that left in the left ventricle. Now what happens in the heart failure? Now heart is unable to pump. So it is unable to pump. So it is unable to meet the metabolic demands of the body. So heart is unable to meet the metabolic demands of the body. This is what is heart failure. And its most important cause is this: myocardial infarction. So others are diseases of myocardium like myocarditis, cardiomyopathy, then volume overload in most of the incompetence, and pressure overload in most of the stenosis. But acute MI, acute myocardial infarction, that leads to acute heart failure. As you have to treat it totally in a different way because it is an emergency. Now, what are the various type of heart failure? See, first is acute heart failure, which develops suddenly. Chronic heart failure, which develops gradually over the time. Then right, left, and biventricular failure. Right heart failure it is going to involve the right side of the heart, right unit. Left is going to involve the left side of the heart, and biventricular failure, that is going to involve both the sides. Now forward and backward failure. Forward failure is where heart is unable to pump. Okay? So cardiac output will be less in the forward heart failure. Whereas in backward failure, the blood will accumulate in the heart and ultimately it is going to accumulate in the veins, and that leads to congestion. Agar if it is on the right side, it is going to cause a peripheral congestion and hepatomegaly. If it is on the left side, it is going to cause a pulmonary congestion and edema. Next is diastolic and systolic dysfunction. Systolic dysfunction, where heart is not able to contract. Heart is not able to pump the blood. That is because of systolic dysfunction. Diastolic, where heart is not able to relax. So here the end diastolic volume will be less. Then high output and low output failure. High output may there the cardiac output, that is normal. In high output failure, the cardiac output is normal, but the metabolic demand of the body that increases. ये ज़्यादा हो जाती है. Cardiac output को कोई problem नहीं आती. So what are the condition where the metabolic demand of the body that is increased? Number one is anemia. Then we have a thyrotoxicosis, and then AV shunt. These are the three conditions where the metabolic demand of the body is increased. And especially remember these first two. And here what is the treatment? You have to treat the cause. Anemia है तो उसमें आप patient को you have to treat the anemia, and if it is a thyrotoxicosis, you have to give the treatment for the thyrotoxicosis. Now coming to the low output failure. Here the cardiac output that is decreased. This is what where we are going to put the patient on various type of drug. Okay, so cardiac output that is decreased. When this is decreased, then the metabolic demand of the body, heart is not able to meet the metabolic demand of the uh, body. So this is where you need to give a drug to the patient. So just see the pathogenesis of the heart failure. So what happens in a heart failure? If heart is not able to pump the blood through the aorta, then it won't be receiving this left ventricle won't be receiving the blood from the left atrium. यहाँ से blood from the left atrium, it won't be going to the left ventricle, or left ventricle, it won't be receiving the blood from the left atrium. Then where it will be going? If it is not receiving from the left atrium, where it will go? It will be not able to receive the blood from the pulmonary veins. Then there will be pulmonary congestion. So first thing is, now heart is not able to pump the blood through the aorta, that is low cardiac output. So symptom of low cardiac output, like there will be tiredness, shortness of breath and dyspnea will be there if it is not able to pump the blood through the aorta. Second thing is, तो पहला ये हो गया, if it is not able to pump the blood through the aorta, decreased cardiac output, all these symptoms will be there. Now, if it is not able to pump the blood, then second thing is it won't be able to receive the blood from the atrium, left atrium. Then left atrium won't be able to receive the blood from the pulmonary veins. Then blood will be where it will be? It will be accumulated in the lungs. That leads to pulmonary congestion. And if the same thing happens on the right side, then what will happen? The person will have a peripheral edema and hepatomegaly. Now at this phase, this is acute heart failure. Very common cause is acute myocardial infarction. Now what is the aim of the treatment? And acute heart failure, it is also called decompensated heart failure. Remember this thing. It is also called decompensated heart failure. Now what you are going to give the drugs at this phase? So aim is you have to decrease the fluid. This is number one. And you have to increase the cardiac output. How we can decrease the fluid? By giving the diuretics. आप patient को क्या दोगे? Diuretics. And which diuretic we are going to give? It is a high ceiling diuretic. Furosemide, that is because it is a faster acting, it is a short acting, it is highly efficacious. So we are going to give furosemide. This is preferred over the thiazide because the faster acting and it is a highly efficacious. You increase the dose and it is going to cause the diuresis. And how this furosemide is going to act? It is going to act on the ascending limb of loop of Henle. The thick part of the ascending limb of loop of Henle, it is going to inhibit sodium potassium 2 chloride co-transport. It is going to cause the, so how it is going to give the relief in the acute CHF? It is going to cause the diuresis. So it is by causing the diuresis, it is going to, person will be relieved from the pulmonary congestion and pulmonary edema. And another is by decreasing the preload. If it is on the right side, अगर ये right side पे काम करता है, it is going to decrease this preload. So this is the way, by causing the diuresis, it is, the person will be relieved from the pulmonary congestion and edema. This way, it is going to give the relief in acute CHF. Second thing is, in acute CHF, why we are preferring the furosemide? Because it increases the renal blood flow. This is the another reason. Second, another is, even before this diuresis action starts, it is going to increase the capacity of this systemic veins. And this action, it is a prostaglandins mediated. This is very helpful in the acute heart failure. Now, out of these two, what are the important side effects which you can see with the furosemide? Almost all the ions, they are lost. So, there will be hypovolemia, there will be hypokalemia will be there. Okay? And almost with both the furosemide दो चाहे आप ये thiazide दो, so hypokalemia will be there, hypovolemia will be there, hyperglycemia will be there, and where the both and hyperuricemia will be there. ये चारों के चारों same है. The only difference is with the calcium ion. The loop diuretic, they are going to lose the calcium. So hypocalcemia, that is seen with the furosemide, whereas hypercalcemia, इसके साथ क्या है, there is increased, and इसके साथ क्या है, there is a decrease. This is the only difference. And this is, we preferred furosemide in the CHF and thiazide in the hypertension. Then another drug which we are going to put the patient in acute heart failure, that is a inotropic drug. Inotropic drug which is going to increase the cardiac contractility. By increasing the cardiac contractility, they are going to increase the cardiac output. So important drug, what are the receptors which are there in the heart? It is a beta 1 receptor. So we are going to give the beta 1 agonistic drug for this. So what are the drugs under this comes? Dobutamine, then we have dopamine, then another group of drug is phosphodiesterase inhibitor. We have ambrinon, milrinon and levosimendan. ये अभी आप काट दो. Then another group of drug is synthetic BNP, nasiditide. This also causes the natriuresis, just like this one. Diuretic, this also causes a natriuresis. This I will be covering under the newer drug. And vasodilatation. These are the two important effects with the nasiditide or synthetic BNP, that is a brain natriuretic peptide. Now how this dobutamine it is going to act? So dobutamine, it is a beta 1 agonist. So what receptor are there in the heart? It is a beta 1 receptor, they are there. We are going to give 2 to 5 microgram per kg per minute. This is going to stimulate on beta 1 receptor and it is going to give a positive inotropic action. So cardiac output will be, cardiac contractility is increased, so cardiac output will be increased. This is how dobutamine it is going to act. तो हमने एक ये ड्रग देनी है. Second one is a dopamine. Dopamine, it has got the dose dependent action. So this is going to stimulate all the receptor, dopamine, then beta receptor, dopamine, beta and alpha. So it has got the dose dependent action. At low dose, 2 to 5 microgram per kg per minute. So I'll write here 2 to 5 microgram. This is about the dopamine. Per minute, it is going to stimulate the D1 receptor. Then 5 to 10 microgram per kg per minute, it is going to stimulate both dopamine 1 receptor and beta 1 receptor. And you can say more than 10 or 10 to 15 or more than 15, more than 10 microgram, it is going to stimulate the alpha receptor. So this is the dose which we gave. So D1 receptor, they are present in the mesenteric blood vessels, in the renal blood vessels. So if we are going to use this dose 5 to 10, it is going to cause a vasodilatation of the renal blood vessels or the mesenteric. So blood supply is sufficient to that part, and along with that it is also going to stimulate the beta 1 receptor which are present in the heart. So positive inotropic action will be seen. So inotropic drug, we are giving the dobutamine and dopamine. So another group of drug is inotropic is phosphodiesterase inhibitor. It is also called PDE. So they are PDE3 inhibitors. You know what the action of this PD phosphodiesterase enzyme? So usually this adenyl cyclase pathway, where what they do, if you remember the general pharmacology, the ATP, that is G protein couple receptor, how they act, G protein couple receptor, where the second messenger is adenyl cyclase. So this adenyl cyclase, what they do, they are going to convert ATP into cyclic AMP. Now this cyclic AMP, it is going to cause the phosphorylation of protein kinase A, and this further it is going to cause the phosphorylation of many enzyme, many transporter at different site, and going to perform the many action. So important action in the heart and in the smooth muscles like bronchi smooth muscle or the blood vessels. वहाँ पे क्या heart में it is going to increase the cardiac output, whereas in the smooth muscle it is going to cause the relaxation. Okay. Now this cyclic AMP, it is degraded by the phosphodiesterase enzyme. It is degraded by the phosphodiesterase enzyme. Now if I give phosphodiesterase inhibitor, ये वाला, this 3 inhibitor, where it is present? It is present in the heart, number 1, and number 2 in the smooth muscle, number 3 in the smooth muscles of blood vessels and smooth muscles of bronchi. So these are the 3 important sites where this enzyme phosphodiesterase, they are there. So phosphodiesterase 3, I am talking about the 3, they are there. Now this cyclic AMP, it is degraded at these 3 sites, heart phase, smooth muscles of blood vessels and bronchi, by phosphodiesterase 3 enzyme. Now if I give this phosphodiesterase 3 inhibitor, ठीक है, अगर मैं यहाँ पे phosphodiesterase 3 inhibitor if I give, like inamrinone, then milrinone, then levodopa, अगर मैं ये तीनों ये यहाँ पे दे देती हूँ, then it is going to inhibit this, then indirectly it is going to increase the concentration of this cyclic AMP. That leads to phosphorylation of protein kinase A, and then what will happen? It is going to increase the cardiac output by increasing the level of calcium, and it is also going to cause the relaxation of the smooth muscles, especially blood vessels. So this group of drug, it is also very commonly, it is called as inodilators. Inodilator is, they have got inotropic action, INO, inotropic, so ये inotropic action हो गया. Then dilator is blood vessel dilator. So this way, so inamrinone, it is not used nowadays because of its important side effect, that is thrombocytopenia and few of the GIT, but it is mainly because of the thrombocytopenia we are not using inamrinone. So, and half-life of this one is 2 to 3 hours. Then we prefer milrinone. ठीक है, so इसमें आपके कौन कौन से हैं ड्रग? वी हैव inamrinone. इससे क्या है? thrombocytopenia, that is a very common side effect along with the GIT, and half life इसकी क्या है? 2 to 3 hours, and we are not using because of this. So what we give now to the patient? We are using milrinone. No thrombocytopenia. It is more potent, 10 times more potent, and half-life is 1.5 hours, or you can say 80 minutes. Then levosimendan. लिवोसिमेंटिन का थोड़ा सा है. लिवोसिमेंटिन अपार्ट फ्रॉम दिस इट इज अ फॉस्फोडाइस्ट्रेज 3 इनहिबिटर. इट इज गोइंग टू, एक ये तो एक्शन है, इट इज गोइंग टू सेंसिटाइज द myocardial tropin C to the calcium. Then it is also going to open the ATP sensitive potassium channel. Otherwise this is also a inodilator. इसमें 3 मैकेनिज्म है. लिवोसिमेंटिन. Now here what I want to say, the important thing is this drug we give it by IV route. They are the short acting, half life देखो, they are the short acting. So where they will be used? They will be used in acute heart failure. Same if I take up this dobutamine and dopamine. Dopamine we give it by continuous infusion. It is a half life is so short. So all these drugs, the beta 1 agonist drug and phosphodiesterase, we are going to use in acute heart failure. इसको हम एक्यूट हार्ट फेलियर में पेशेंट को देंगे बिकॉज वी आर गेमिंग इट बाय आईवी रूट. दे आर द शॉर्ट एक्टिंग एंड एक्यूट हार्ट फेलियर दिस इज एमरजेंसी. सो जो भी हम ड्रग देंगे, द ड्रग विच वी आर गोइंग टू पुट द पेशेंट, गिव इट बाय आईवी route. So few other drugs which we can use in the acute heart failure, like the latest edition of Goodman Gilman in even the Tripathi, they also write. So other group of the drug which we can put the patient on this is vasodilators, like glycerol trinitrate IV. So this, when I will be taking the vasodilator, that time I will cover up how it is going to help in acute CHF patient. Another drug is like we are putting the patient on furosemide. Along with that, with the acute heart failure, you can give the, if it is acute left ventricular failure, we can give the morphine. This also shifts the pulmonary fluid to the system, fluid from the pulmonary circulation to the systemic circulation. तो आप ये वाला भी patient को, you can put the patient on this, and if patient does not show the response, then we can give this necititide, which is going to produce the both natriuresis as well as vasodilator, and then IV vasodilator like glycerol trinitrate that can also be given to the patient. Will be taking with the vasodilator. So this is what is the drug we use it for the acute heart failure. Now coming to, for the acute heart failure, we have given the treatment. Now body itself, so heart failure में क्या, there is a decrease in contractility and decreased cardiac output. Now because of the decreased cardiac output, the tissue perfusion, patient का क्या, tissue perfusion will be hampered. There is no sufficient tissue perfusion. Now then what will happen? There will be activation of the compensatory mechanism. अब compensatory mechanism कौन सा है? It is a, because emergency है, fight and flight, वो वाला system, तो sympathetic system will be activated. With the activation of the sympathetic nervous system, what all the receptor will be activated? It will be alpha and beta. Now alpha receptor, they are present where? They are present in the blood vessels. So alpha, they are going to cause the vasoconstriction both in the artery as well as in the vein. Now beta receptor, where they are present, especially the beta 1, they are present in the heart and in the JG cell of the kidney. So in the heart, what they are going to do, they are going to cause the contraction. Okay, I again repeat, because of the decreased tissue perfusion, ये वाला काम हुआ, then what will happen? There will be activation of the compensatory mechanism, and because it is a emergency, fight and flight system will be activated, so sympathetic activity will be there. This system will get activated. Okay? And with the sympathetic nervous system, it is going to act, there will be what release? Epinephrine, norepinephrine. This is going to act through what? Through the alpha receptor, ये वाला, and beta. With the alpha receptor, they are going to cause the vasoconstriction of the veins as well as artery. With the beta 1 receptor, they are going to increase the contractility and there will be increase in cardiac output. Now this decreased tissue perfusion, okay, that itself is going to activate the renin release, plus the beta 1 receptor, they are also there. It is going, there is a stimulation of the beta 1 receptor not only in the heart but also in the JG cell of the kidney. तो ये भी आपके एक्टिवेट हो गए. This is once this is JG cell of the kidney is activated, they are going to cause the release of renin. Now this renin, it is going to act on the angiotensinogen, which comes from the liver. It is going to convert angiotensinogen to generation of angiotensinogen. There will be angiotensin 1. Now this angiotensin, with the help of ACE, angiotensin converting enzyme, which is present in the lung. ये मैंने यहाँ पे lung बनाया so that you can remember it. To the angiotensin 2. Now this angiotensin 2, they are going to act through the angiotensin receptor. Now where these receptors they are present, the most important site is blood vessel, number 1, where it is going to cause a vasoconstriction. Then in the brain, especially the pituitary, which pituitary? It is a posterior pituitary. Posterior pituitary से आपका क्या आता है? ADH, antidiuretic hormone or vasopressin. Another name is vasopressin. Okay? So this is going to cause what? Antidiuretic. So there will be decreased urine output, and this is going to increase the blood volume. Third thing is, it is also this AT receptor, they are also present on the, what is this? Adrenal gland, the cortex of the adrenal gland. So from where what will happen? The aldosterone secretion will be there. And this aldosterone, it is going to exert important action, especially sodium and water retention. That is going to increase the blood volume, and ultimately there is an increase in blood pressure. Now, the blood volume, it is raised here and with this also. If this blood volume, if this is raised, then what will happen? It is going to increase the work of the heart. Here also, the vasoconstriction, because of the vasoconstriction, what will happen? With the veins, there is increase in preload, and if the arteries they are constricted, then it is going to increase the afterload. Now, what is the afterload and what is the preload? ये वाला थोड़ा सा point, just try to understand this point. What is the afterload? Afterload, it is the work which the left ventricle has to work to push the blood into the aorta. Okay? I'll draw here. So how much this left ventricle it has to work? इसको कितना काम करना पड़ता है to push the blood into the aorta? So it depends upon the condition of what? It depends on the, so afterload, it is a how much left ventricle has to work or has to contract to push the blood into the aorta. And it depends on the condition of what? It is going to depend on the condition of arteries or arterioles. So if the arterioles they are constricted, अगर ये यहाँ से blood pump कर रहा है, and if the further there is a constriction of the peripheral, जहाँ पे आपकी constriction है, then if it is constricted, then it has to, heart has to work more. That means the arterial constriction, it is going to increase the after load. And whereas dilatation or relaxation, they are going to decrease the, if it is a dilated, then aram se the blood will move. So it is going to, dilatation is going to decrease the afterload. So this is about the afterload. Now what is the preload? Preload is the end diastolic volume of the left ventricle. So end diastolic means at the, when the heart is relaxing, what is the filling of that heart? So filling happens during the diastole. Filling comes from where? From the peripheral veins. आपकी vena cava, that superior vena cava and inferior vena cava. So ultimately from here, from the right atrium, it will move to the right ventricle, and from here it is going to the pulmonary trunk, and from the pulmonary trunk, where it will go, the blood will move to the lungs, and from the lungs the oxygenation will happen to the blood, and it will come to the pulmonary vein, it will come to the this. So preload, it is this end diastolic, यहाँ पे जो end diastolic preload is end diastolic volume of the left ventricle. So it depends on what? It depends upon the condition of these veins. Peripheral veins. Agar veins, if the veins they are dilated, then what will happen? There will be peripheral pooling. Agar ye aapki dilated hai, peripheral veins puri dilated hai, there will be peripheral pooling of the blood, and less blood will come to the right atrium. Subsequently, less blood will be in the right ventricle, and all over less blood will move from the pulmonary trunk to the lungs, and less blood will be coming to the left atrium, and less blood to the left ventricle. So this is going to decrease the preload, and ultimately if preload is less, heart has to work less. Similarly, if I go this system RAS, it is going to stimulate the RAS, renin, angiotensin, aldosterone system. Here also in the end, because of the increase in the blood volume, it is going to increase both afterload as well as it is going to increase the preload. So ultimately it is going to increase the cardiac work. So what is this compensatory mechanism? How it is going to help? So initially, because of this increased preload, आपका volume बढ़ा, and increased contractility and cardiac output, the heart will be able to meet the metabolic demand of the body. आपका fluid बढ़ गया, preload है, increased contractility, and there is increased cardiac output. So initially there is a beneficial effect, but along with the constriction of the veins, it is also going to constrict the artery. Now again heart has to work more. इसको और ज़्यादा काम करना पड़ेगा. Heart has to work more. So it is going to increase the cardiac work. So oxygen's demand is more. Oxygen demand of the heart, it is more. So ultimately it is going to worsen the condition of the heart. This is number 1. So initially there is improvement because of the increased preload, increased contractility, and increased cardiac output. But later on, because of the constriction of the artery, there is increased afterload. So it is going to increase the cardiac work. Then number 2. Now because of the increased contractility, because of the increased stimulation of the beta-1 receptor, it is increasing the contractility, but later on what will happen? There will be down regulation of this beta-1 receptor, which is again going to worsen the condition of the heart. Number 3, the most important, the compensatory mechanism which is going to operate in the heart, that is the myocardial, local level pe myocardial hypertrophy. So what is that myocardial hypertrophy? There is a dilatation, myocardial hypertrophy, the size of the heart, that is increased. So it is going to even, you can say, the shape of the heart, it will become a spherical, that there will be myocardial hypertrophy. So this myocardial hypertrophy, what is this is because of the mainly aldosterone. There is the presence of aldosterone and angiotensin. These two, they are going to cause a myocardial hypertrophy, plus this all the volume volume overload, they cause a myocardial hypertrophy. So initially this is also beneficial, but later on what will happen, because of this continuous presence of angiotensin and aldosterone, this myocardial hypertrophy, it leads to cardiac remodeling. Now what happens in cardiac remodeling? There is a In cardiac remodeling, there is a proliferation of the connective tissue as well as the proliferation of the myocardial myocytes, and that proliferated myocardial myocytes, they are more prone for the apoptosis. Now what happens? So initially myocardial hypertrophy जो आपकी पहले है, this is helpful. This is So initially it is helpful, but later on it leads to cardiac remodeling, which is again not a beneficial. Now because of the cardiac myocardial hypertrophy, even the demand of the myocardium, that is also increased. So ischemia, ultimately it leads to ischemia. When the cardiac remodeling happens, then what will happen? The cardiac myocyte, though it is a proliferated, but they are prone for the apoptosis. So whatever myocytes they are left, the more burden on them is there. So that also leads to the increase the cardiac power. So cardiac remodeling, it is going to worsen the condition, and this is the one which is going to cause the death of the patient, because ultimately if the myocytes they undergo apoptosis, then what will happen? The heart won't be able to work. So now what is the aim of treatment? So this is how the chronic uh, congestive heart failure this happens. So this is chronic congestive heart failure, that is also called a compensated heart failure. So chronic congestive heart failure को हम क्या बोलते हैं? We say it is a chronic heart failure, that is also called compensated हार्ट फेलियर, क्योंकि यहाँ पे आपका कॉम्पनसेटरी मैकेनिज्म दैट इज ऑपरेटेड, सिंपैथेटिक सिस्टम, आपकी सिंपैथेटिक एक्टिविटी हो गई, एक ये सिस्टम हो गया, सेकंड वन इज रेस सिस्टम, दीज टू सिस्टम दे आर एक्टिवेटेड, ठीक है. एंड देयर आर लोकल ऑल्सो, लाइक देयर इज अ रिलीज ऑफ एंडोथेलिन, देयर इज अ रिलीज ऑफ दिस एडीएच, ये भी आपका हो गया, देयर इज अ रिलीज ऑफ इवन बीएनपी, ब्रेन नाइट्रोयूरेटिक पेप्टाइड, दैट इज ऑल्सो रिलीज विल बी देयर. सो दे आर द अदर कॉम्पनसेटरी मैकेनिज्म, दे ऑल्सो will be operated in the under this compensated heart failure. So this is also called a compensated heart failure. Now here what is the aim of the treatment? Because there is a increase in the afterload and preload, काम बढ़ गया heart का, so we have to give the drug which can decrease the cardiac work. So to decrease the cardiac work, you have to give the drug. Second thing is there is increased blood volume, so you have to give the drug which is going to decrease that. Then अगर if there is a cardiac contractility, it is compromised, then you have to give the drug which causes the contraction of the myocyte or myocardium. Then the most important is you have to give the drug which decreases this cardiac remodeling, जो इसको कम करे, the cardiac remodeling, ठीक है. So this angiotensin and aldosterone, they few books they write angiotensin 2 and few they write aldosterone. So both they are responsible for the cardiac remodeling, and this cardiac remodeling ultimately now it is going to weaken the heart. Cardiac remodeling, it is going to weaken the heart. Now again heart is not able to pump the blood, so there will be back pressure which leads to edema, and ultimately the sign will be this pulmonary congestion, there will be hepatomegaly, there will be peripheral congestion. So all person will come with the peripheral congestion, hepatic congestion and pulmonary congestion along with all these symptoms. So what is the aim of the treatment in the chronic heart failure or compensated heart failure? You have to decrease the cardiac work, reduce edema, increase the cardiac output, and to reverse the disease progression or to reverse the cardiac remodeling. So for each and every patient you have to put the drug which is going to decrease this, or which is going to reverse the disease progression, because this is the one which is going to increase the survival of the patient. ठीक है, to decrease the cardiac work and to reduce the, यहाँ पे हम patient को क्या देंगे, we are going to put the patient on vasodilator. To reduce the edema, we are going to put the patient on diuretics, and to increase the cardiac output, यहाँ पे हम we are going to put the patient on oral drug, and the most important group of drug is cardiac glycosides. Now, what are the drugs which are going to reverse the disease progression or to increase the survival? ठीक है, so यहाँ पे हम क्या देंगे? Now, the main problem with the we want to reverse what? We want to reverse the cardiac remodeling. हमने किसको reverse करना? We want to reverse the cardiac remodeling, and cardiac remodeling it is happening due to what? Cardiac remodeling किस वजह से है? Cardiac remodeling is because of the angiotensin 2 and because of the aldosterone. तो आपका cardiac remodeling किस वजह से? Cardiac remodeling is because of the stimulation of this RAS system. So you have to give the drug which is going to block this RAS system. तो RAS system की activation कहाँ से शुरू हुई? From this beta 1. So beta 1 they are going to activate this JG cell. तो सबसे पहले हम क्या देंगे पेशेंट को? बीटा ब्लॉकर, बीटा 1 ब्लॉकर कार्डियो सिलेक्टिव आप दे सकते हैं पेशेंट को. देन व्हाट एल्स वी कैन गिव? वी कैन गिव नंबर 1 इज दिस. ठीक है, सो नंबर 2 इज वी कैन पुट द पेशेंट ऑन एस इनहिबिटर. सो बीटा 1 ब्लॉकर जैसे क्या हो गया आपका? मीटोप्रोलॉल हो गया, आपका बाइसोप्रोलॉल, देन नॉन सिलेक्टिव लाइक कार्बिडिलॉल. एस इनहिबिटर आपका कैप्टोप्रिल, ठीक है, इनालाप्रिल, लाइसिनोप्रिल, वो वाले आगे एस इनहिबिटर. एंजियोटेंसिन कन्वर्टिंग एंजाइम इनहिबिटर which is going to inhibit this conversion of angiotensin 1 to angiotensin 2. Then we have a angiotensin receptor ARB which is going to block this AT1 receptor, which is further going to act at the 3 sites. जो आगे further 3 sites पे act करती है, it is going to act on that. Then another one is there is a release of aldosterone, so we can put the patient on aldosterone antagonist. So number 3 is ARB and number 4 in aldosterone receptor antagonist. So these are 4 group of the drug which is going to reverse the cardiac remodeling, which is going to increase the survival of the patient. I again repeat, because the cardiac remodeling you want to increase the survival by inhibiting this cardiac remodeling. आपको ये वाली inhibit करनी है. You have to reverse this cardiac remodeling. And how you can reverse this cardiac remodeling? Because cardiac remodeling, that is mainly because of the stimulation of aldosterone and angiotensin 2. So we have to give the drug which can block this RAS pathway, and it starts with the stimulation of beta 1 receptor which is going to cause the activation of the JG cell. ठीक है, इसको जब stimulate करती JG cell को, so we have to give the drug which is going to act this way. ठीक है, तो जब हम इसको इस तरह से देंगे which is going to act on this and JG cell, and then all these steps, beta 1 receptor दे दो, ACE inhibitor दे दो, then ARB angiotensin receptor blocker and aldosterone receptor antagonist. You can see in the next slides, to decrease the cardiac work, we are putting the patient on vasodilator. To reduce the edema, we are giving diuretics. To increase the cardiac output, we are giving the cardiac glycosides. And to reverse the disease progression, we are giving a beta blocker, ACE inhibitor, all that, the pathway, RAS pathway. Okay? So now coming to the which is going to decrease the cardiac work, vasodilator. Cardiac work ऐसे we are going to give the drug which is going to decrease the preload and which are going to decrease the afterload. कैसे होगा बेटा आपका which is drug which is so vasodilator, how they are going to act? Vasodilator we give venodilator or drugs which is going to dilate the veins. We give arterial dilator, which is going to dilate the artery, and we give the mixed one. So mainly one drug. Venodilator, the most important is nitrate. इसमें क्या आएगी आपकी हाइड्रोलाजेन. इसमें क्या आएगा आपका sodium nitroprusside. These are the drugs. Now nitrate, how they are going to act? They are going to act by causing the release of NO. ठीक है, aldehyde dehydrogenase पे act करके they are going to cause the release of NO. So which is going to activate the guanyl cyclase. So ultimately the cyclic GMP, they are going to cause the dephosphorylation of myosin light chain kinase. इसकी dephosphorylation, phosphorylation नहीं होने देता, and this is going to cause what? This is going to cause the smooth muscle relaxation. And smooth muscle relaxation किसकी ज़्यादा होगी? It is more for the veins as compared to the artery. So they are the venodilator. So I already told preload is end diastolic volume of left ventricle. It depends on the status of the veins. So if veins they are dilated, there will be peripheral pool of the blood and less blood will be there in the left ventricle at the end of the diastole. So if we are going to give the nitrate, they are going to cause the venodilator. There will be peripheral pooling of the blood. So preload ये आपका काम करेगा. There will be peripheral pooling of the blood will be there, and it is going to decrease the preload. Now, what is the role, and usually what is the role of this venodilator in the acute? So in the acute CHF, what two drugs, what are the aim in acute CHF? We are giving the diuretic. हमने क्या congestion काम करना, pulmonary congestion we want to decrease. So for that, what we are giving to the patient to decrease the pulmonary congestion? We are putting the patient on furosemide. ये दिया आपने IV. Then to increase the cardiac output, we are putting the patient on dobutamine. Then to decrease the cardiac work or to decrease the preload, अगर आपका उधर hepatomegaly and everything, we can add IV glycerol trinitrate, the acute heart failure itself. So the three drugs we can give. So have to be careful. Then this. So in acute left ventricular failure, which is due to AMI, we can put the patient on these three drugs. Then vasodilator, hydrolysis, arteriolar dilator. So arteriolar dilator, on this what depends? It is a afterload. That depends on the condition of the artery. So if arteries they are dilated, heart has to work less. Heart has to work less to pump the blood from the left ventricle to the aorta to rest of the body. So hydrolyzing, they are going to cause the dilatation of the artery. So heart has to work less. So they are going to decrease the, they are going to decrease what? They are going to decrease the afterload. And this is going to decrease the nitrates preload. So they say this combination of these two. So usually the drug which improves the survival, they are the drug which mainly act on the RAS system. But the combination of this nitrate and or venodilator and arteriolar dilator, they also improves the survival. कौन सा combination? Iso sorbide dinitrate So with this we are giving hydralazine. This also improves the survival of the patient. Why? Because hydralazine, it causes the renal vasodilatation. ये renal vasodilatation करते हैं. So usually to improve the survival, we have to give the drug which act on the RAS. समझ लो angiotensin converting enzyme inhibitor or ARB. There are the few patients where this drug they are contraindicated, especially if there is a renal insufficiency, if there is a renal artery stenosis, then we cannot give the drug that is like ACE inhibitor. हम नहीं दे सकते तब. We cannot give the ACE inhibitor and we cannot give the ARB. So that time this combination, this also improves the survival. Then coming to this is sodium nitroprusside. This is a mixed one. We give it by IV route. So this is going to cause both venodilatation and arteriolar dilatation. So they are going to decrease both preload as well as they are going to decrease the afterload. So careful administration of sodium nitroprusside can also be done even in acute heart failure along with this diuretic and along with this inotropic drug. So this drug, it is going to decrease both preload and afterload. It is going to decrease the cardiac work. So this is about the vasodilator. So next group of drug is diuretic. Here diuretic already I have told we have to reduce the edema. Okay? So we have to reduce the edema. अगर आपको लगता है, so again here we are going to prefer the furosemide. Okay? But usually what happens in chronic heart failure, we have to put the patient this group of drug. We want to improve the survival. So usually we start with this ACE inhibitor and ARB, any one of these two, plus minus beta blocker, and then we add this diuretic intermittently. Now what is the reason for that? Why we have to add in the chronic CHF diuretic intermittently? Because especially the initial what we say, when it is a compensatory heart failure, the initial cardiac output, that is जो आपका initial है, the improvement in the cardiac output, that is mainly because of this preload. Okay? If we are going to give the and second thing is, if you are going to give the diuretic, then the initial that preload on which mainly your this cardiac output depends, it is going to decrease that. Number one, this. Number two, because of the depletion, volume depletion, it is going to activate this system, RAS system. So if this system gets activated, then it is going to cause the cardiac remodeling and the condition of the person, it worsens. So you have to put in chronic heart failure, आपको ACE inhibitor or angiotensin receptor blocker along with that beta blocker and diuretic furosemide you have to add intermittently whenever fluid is there. Only if there is a sufficient fluid, आपको ये लगता है whenever you withdraw that and again the fluid gets accumulate, then you can give a continuous diuretic, oral therapy of diuretic, but you have to be careful about the dose. Dose has to be titrated so that there should not be depletion of the volume, there should not be activation of this RAS system. Okay? Hope you understood. So diuretic, it is going to stimulate by the volume depletion, it is going to stimulate what? It is going to stimulate this RAS system. And this RAS system, this is responsible for the cardiac remodeling. So if you are going to put the patient on the diuretic and the continuously, it is going to worsen this cardiac remodeling. So diuretic, they are going to give only symptomatic improvement in the patient. They are not going to affect the survival. So this is a diuretic. Then coming to the cardiac glycosides. So this I will be taking in the next lecture. I will start with the cardiac leukocytes, what are their mechanism of action, how they act. So I will be covering in my next video. So if you have any query regarding this video, you can ask that query in the comment box. So if you like my video, please subscribe my channel and put up your important suggestion in the comment box.